Hello everyone, this is Dr. Frances Munroe, and today I'm going to talk with you about the topic of kidney stones. This slide set is based upon a comparative effectiveness review called Recurrent Nephrolithiasis in Adults, Comparative Effectiveness of Preventive Medical Strategies. This was developed by the Minnesota Evidence-Based Practice Center of the Agency for Healthcare Research and Quality. This presentation will begin with an introduction to the topic of recurrent kidney stone, the types of therapies that are currently available for treatment. It will also cover methods used to plan and execute the systematic review, some very clinically important questions that they were looking for answers, and results of the review, evidence-based conclusions about the benefits and safety of current available treatments to prevent kidney stones, what are some of the gaps in knowledge, and the future research needs that were uncovered by the systematic review. The formation and incidence of kidney stones is a very important topic. Nephrolithiasis is a very common condition in which hard masses, otherwise known as kidney stones, form within the urinary tract. These stones form from crystals that separate out of urine. The formation may occur when the urinary concentration of different types of crystal-forming substances is high, and or that of substances that inhibit stone formation, such as citrate, is low. The lifetime incidence of kidney stones occurring is approximately 13% for men and 7% for women. Reports vary about whether the incidence is rising overall, but they do see an incidence increasing in women and a falling male to female ratio. They are seeing an increase in children, possibly due to childhood obesity rates rising. Among adults with kidney stones, approximately 80% consist predominantly of calcium oxalate and or calcium phosphate stones. Struvite stones and uric acid stones each account for about 5 to 10% of stones, and cysteine stones are quite rare. So what does the typical patient look like clinically when they present with a complaint of kidney stones? Well, oftentimes kidney stones are incidentally identified when the patient is undergoing plain radiographs or CT scan for some other reason. However, stones may become symptomatic when they pass out of the renal pelvis, go into the ureter, with potential symptoms including extreme pain, renal colic, with abdominal and flank pain, nausea and vomiting, urinary urgency, hematuria, urinary tract obstruction, infection, and sometimes an impairment in kidney function. Some studies have shown that kidney stones may increase the risk of chronic kidney disease. They certainly can lead to more hospitalizations and procedure-related morbidity. What are some of the risk factors for developing kidney stones? Well, in many patients, urinary stones and biochemical abnormalities are caused by an interaction both between genetic tendencies and environmental exposures. Genetic factors are thought to account for about half of the risk of developing kidney stones. Environmental factors have shown to include low fluid intake, low calcium intake, and a high fructose intake may increase stone risk. While evidence is still mixed regarding high amounts of animal protein, increased sodium, increased sucrose, and low magnesium. Some medical conditions can also predispose a patient to the higher risk of kidney stones. This would include a primary hyperparathyroidism, obesity, diabetes, gout, and sometimes anatomical abnormalities such as a medullary sponge kidney or horseshoe kidney. Some medications may also cause kidney stones, including triamterene, also known as Maxide, Topamax, and Crixivan. Following an initial occurrence of a kidney stone, the 5-year recurrence rate in the absence of any specific treatment is pretty high at about 35 to 50%. Recurrence is usually diagnosed by radiographic studies, either by a symptomatic reoccurrence or by a composite definition that's a combination of both. As mentioned earlier, it is important to diagnose kidney stone recurrence because it can increase the risk of developing chronic kidney disease. What are the radiological tests that may be ordered? A very popular one is the non-contrast helical CT scan. It is 97% sensitive for ureteral stones. IVP has about a third radiation of CT scans, but there is always the risk of problems with the dye. And a KUB of the abdomen is especially good for radio-opaque stones, including calcium and cysteine. Renal ultrasound is very useful for long-term follow-up of asymptomatic stones or in pregnant patients where you may be doing multiple studies. Almost 98% of all kidney stones less than half a centimeter will pass on their own. Referral to a urologist, however, is warranted when more than one stone is present, when symptoms worsen with fever, renal function is impaired, stone passage is very prolonged, hydronephrosis is diagnosed based on imaging findings, the patient is pregnant, or the stone is larger as measured by CT or ultrasound. Urologists are increasingly using ureteroscopy to remove stones and evaluate for changes in the uroepithelial lining. Oral hydration and pain management are a big part of the acute treatment of any type of kidney stone. For stones that measure 10 millimeters or less, you can try some antispasmodics such as calcium channel blockers or alpha blockers. They will help relax the smooth muscle of the ureters, and they can hasten stone passage by 5 to 7 days. Administration of oral steroids leads to little or no improvement, and patients who are unable to take oral fluids or medications, or people with low blood pressure, should be treated with intravenous fluids. If signs of infection are present, then empiric antibiotics that cover gram-negative bacilli should be prescribed. Again, a referral to a urologist should be expedited if the patient also shows radiologic evidence of obstruction, otherwise known as hydronephrosis. Lithotripsy is only done by the urologist, and it is usually indicated only for smaller stones. The advantages are that it is non-invasive. However, disadvantages include an increased risk of injury to the calcified arteries and aneurysms, and the possibility of small stone fragments breaking off. There are several interventions for preventing kidney stone recurrence. These include both dietary interventions and pharmacological interventions. The dietary interventions are designed to alter the concentration of one or more of the crystal-forming or crystal-inhibiting substances in the urine. So a large water intake will increase the urine volume and lower the concentration of any crystal-forming substances. Some other dietary interventions include reducing dietary oxalate to lower the risk of calcium oxalate stones, reducing dietary animal protein and other purines to lower uric acid, and maintaining a normal dietary calcium to help to bind the intestinal oxalate. Different pharmacological therapies have been tried, and thiazide diuretics and citrate therapy have been most effective in reducing stone recurrence. Some other drugs that have been tried include allopurinol, magnesium hydroxide, and acetohydroxamic acid. This comparative effectiveness review is going to look at specific clinical questions. They studied adults with a history of kidney stones and wanted to look at results of baseline stone composition, blood and urine chemistries, and whether they predict the effectiveness of diet or medication treatment on final health outcome or stone formation. Another question was the effectiveness of different dietary therapies on final health outcomes and intermediate stone outcomes. One of the other questions was the evidence that dietary treatments to reduce stone episodes are associated with any adverse effects themselves, and what are the effectiveness of different pharmacological treatments on final health outcomes and stone outcomes. The strength of evidence was classified into 4 broad categories, as you can see by the chart on the screen. These strength of evidence ratings were used throughout, assessing 4 domains: risk of bias, consistency, directness, and precision. If we look at the first table, this lists the comparative effects of various dietary interventions on the risk of stone formation, along with their ratings. The ones discussed on this slide include increasing fluid intake and eliminating soft drink intake. Specifically, when increased fluid intake maintained a daily urine output of greater than 2 liters per day, there was a significant reduction in stone recurrence compared to no increase in fluid intake. Advice to reduce soft drink intake also reduced symptomatic stone recurrence. With a baseline soft drink consumption of greater than 160 milliliters per day, there was a 7% absolute reduction in self-reported renal colic episodes. This was compared to patients abstaining from soft drink intake versus no intervention for 3 years. The benefit was restricted to participants for whom the soft drink most frequently consumed was acidified solely by phosphoric acid, but not by citric acid. The next slide takes a look at the effects of dietary interventions, but this table looks at a low-protein, high-calcium diet and the intake of a tailored diet based on a metabolic evaluation. As you can see, a multi-component diet including normal calcium, low protein, and low sodium did reduce the risk of stone recurrence when compared with just a low-calcium diet. This was measured over a 5-year period, and both groups were advised to increase their fluid intake and decrease oxalate intake. In the second part of this trial, the participants were limited to a biochemical evaluation with just general diet recommendations versus an extensive metabolic evaluation and diet recommendations tailored to that. So what are some of the pharmacological interventions that we can use to reduce the risk of kidney stone recurrence? There is moderate strength evidence that thiazides significantly reduce the risk of recurrent calcium stones. There were 6 trials that reported stone recurrence, and it was significantly lower in individuals that were randomized to thiazide rather than to placebo or the control group. No specific trial directly compared each of these agents or the dosages of agents, and no trial really looked at the lower thiazide doses that are most often used to treat hypertension. The strength of evidence for this study was moderate. There were 4 trials that reported a stone recurrence outcome looking at the use of citrate compared to placebo or controlled, and the recurrence risk was significantly lower in the individuals randomized to citrate than the other groups. The results appear very similar for those including potassium citrate, potassium magnesium citrate, and potassium sodium citrate. These studies also found that allopurinol, which is often used for gout, does reduce the risk of calcium stone recurrence in patients with elevated blood and urine uric acid levels. Again, the strength of this was moderate. And lastly, there was no additional benefit noted from adding citrate to a thiazide diuretic in patients 35% who had hypercalciuria and 15% who had hypocitraturia. Treatment with magnesium, however, did not reduce the risk of kidney stone recurrence when compared to placebo, and neither did acetohydroxamic acid. This was also not found to reduce the incidence of chronic urinary tract infections or struvite stones. Both of these had low to insufficient strength of evidence. There were several conclusions from this comparative effectiveness review done by AHRQ. Some of the conclusions regarding the effectiveness of dietary interventions found that fluid intake greater than 2 liters per day may provide a significant reduction in the risk of stones recurring. Abstaining from soft drinks or eliminating those that are acidified solely with phosphoric acid but not citric acid will reduce a risk of stone recurrence in people drinking soda daily. As far as diet, a normal calcium, low sodium, low animal protein diet may be helpful, but the independent effect of increasing calcium has not been proven to be effective. High fiber, reduced animal protein diets have not been shown to prevent stone recurrence, and the effectiveness of other dietary interventions was not clear. Looking at pharmacological interventions, thiazide diuretics, citrate, and allopurinol, each combined with increased fluid, did reduce the risk of calcium stone recurrence more than just the fluids alone. And allopurinol treatment also reduced the rate of stone recurrence for patients with elevated blood or urine levels of uric acid. So thiazides or citrates may be preferred initial therapy over allopurinol in patients with calcium stones. And patients receiving pharmacological interventions can have some side effects that lead to withdrawal from the treatment. Clinical studies did not clearly establish the need for follow-up blood or 24-hour urine evaluations in predicting stone recurrence. Some of the generalized findings for all trials, they were limited to patients who had a history of calcium stones. Most of the participants were young to middle-aged men. People with biochemical abnormalities were excluded. Same thing with people who did not have risk factors that would predispose them to stone formation. There were several gaps in knowledge identified from these studies. There is no direct evidence whether diets that increase calcium or lower sodium or oxalate or purine reduce the risk of stones, and direct comparisons of each of these dietary interventions to each other or the pharmacological interventions to each other were rare or absent. The effect of dietary and pharmacological interventions on stone types other than calcium stones was also not examined, and the trials did not assess the effectiveness of the lower thiazide doses that we often use to treat hypertension. So future studies are needed to formally test whether any of these things can impact the risk for stone recurrence, and whether additional diagnostic testing would be helpful. So what kinds of things should we discuss with our patients? Most importantly, that kidney stones have a very high chance of recurring if they're not managed properly, that it's very important of maintaining a large daily water intake to achieve urine output of greater than 2 liters per day. We can discuss the benefits and side effects of certain medications for preventing kidney stone recurrence, especially the thiazide diuretics and allopurinol. And we may want to encourage some dietary changes that may be beneficial in preventing recurrence, such as eliminating soft drinks that have phosphoric acid, increasing calcium-rich foods, and limiting foods that contain oxalate. For further information, please look at the AHRQ website, effectivehealthcare.ahrq.gov, under kidney stones for additional references and resources. Thank you.